get started because we have got lots to cover today. So I'm just going to begin with a very good afternoon, everyone, and a big warm welcome. Thank you so much for taking the time to join us today to discuss how we can maximise the impact of GLP-1s through holistic patient support. Really appreciate that it's a busy time of year, so thank you for carving out this hour with us today. I'm sorry to ask, can everyone just pop themselves on mute? Would be fab. If you haven't done so already, just because I think I can hear a bit of feedback and always a bit devastated if it's yourself. Sorry, everyone. Is it all right just to pop yourselves on mute? Thanks, everyone. Perfect. I was going to go and say a quick bit of housekeeping, but you're probably sick of me saying this at this moment in time. Please pop yourself on mute throughout. Would love to see your faces, but appreciate it might not be appropriate or you're able to do so. But please keep your cameras on if possible and your mics off to avoid any background noise. We really want this to be an interactive session. So throughout all of our speakers today, if you have any questions or queries coming to your mind, just pop them in the chat. We're going to make sure we reserve the last 10 to 15 minutes to answer as many questions as possible. And don't worry, if you ask a question and we don't get time to get to it, we're going to write up the responses to any that we don't get time to respond to. And also just to let you know that we are indeed recording today. So for people that have signed up and can't be here today, we're making sure that we have this on record. So I am Lucy Diamond. I am VP of Patient Outcomes here at Oviva. I'm a dietitian by trade. I spent a decade in the NHS and then I have spent the last decade of my career in digital health here at Oviva. And it is an honour to be welcoming colleagues of mine today. So we've got the brilliant Dr. Shane Mehta, our medical director, our amazing Ikavina, our senior clinical psychologist, and our fabulous Juliet Finney, our clinical expert dietitian. So just to give you a little bit of a run through of what we're going to cover today, we're going to take you through the why and the how of medical obesity care and really specifically looking at how nutrition, lifestyle and psychological support aren't just add-ons to weight loss medication, but the engines that really drive long-term success. And just about to
passionately as possible. And
so sorry guys, can I just ask you to pop yourself on mute if you're just joining?
Yeah. So yeah, fingers crossed.
No, that's cool.
Apologies, I've got a bit of background noise. It's okay just to pop yourself on mute. Sorry. Perfect. So I'm just going to give a very brief intro about Oviva for those of you who are new to Oviva. Next slide, if please possible. So we are the leading provider of weight management services for the NHS, and hopefully our mission is simple: to provide the most accessible, effective care, really leveraging cutting-edge technology. To date, across Europe, we have supported 1 million patients, and whilst we work across the NHS framework from diabetes prevention to type 2 diabetes remission, we're here today to specifically talk about our Tier 3 weight management service in a little bit more depth. And we achieve results by blending that high quality clinical workforce, endocrinologists, nurses, dietitians, psychologists, with bespoke technology that really focuses on supporting someone to change their behaviour. And this allows us to deliver personalised remote monitoring and support that can scale across greater patient numbers without losing that human touch. And to give you an idea of that scale, we've worked with over 27,000 patients so far, treating roughly 8,000 people every single month. We're present in all ICBs, and our patients proudly achieve outstanding clinical outcomes with an average of 15% weight loss at that 12-month mark. And finally, we lead with medical expertise. Our growing team includes over 20 endocrinology consultants, specialist GPs, and nearly 300 clinical team members across nursing, psychology, and dietetics. And so you're in very safe hands today on this call, and I'm going to stop talking. I'm going to hand over to the experts here today, heading up with Shane.
Thanks, Lucy. So I'm Shane Mehta, Medical Director with Oviva. I'm also a practicing NHS GP and have experience providing ICB clinical leadership for obesity and diabetes care. So in the next 10 minutes, I'm going to take you through a high-level overview of the evidence base of why we treat obesity and the case for that, and also outline how we deliver medical obesity care at Oviva. So this will come as no surprise to most of you on the call, but obesity is associated with a number of conditions. It's the leading risk factor for cancer, only second to smoking. And we know that it's one of the main drivers for type 2 diabetes. And this is a particular concern for us in the UK. In the last few years, we've seen a surge in type 2 diabetes under 40, and obesity is a key driver of that. Very specifically, when we look at the economic modelling and look at the cost to the NHS, the cost of treating diabetes and the complications of that alone are in excess of 19 billion. And really, the end effects of obesity mean it's too late for prevention alone. So why does, what can we achieve with weight loss? Why does it matter? If we look at the next slide, we can see that essentially there are incremental improvements in weight loss that have impact on a multitude of conditions. Some of these predictable, cardiovascular conditions, you'll see a reduction in hypertension, an improvement in cholesterol with even small amounts of weight loss in perhaps the 5% range. But you'll also see an impact on other conditions like osteoarthritis, and trial data also shows improvements in asthma and sleep apnea, for example. So there are wide-reaching benefits to other comorbidities with weight loss. If we look at the landmark trials for the key drugs that we have in this space, Wegovy and Mounjaro, it's really evident that in recent years, the thing that's really changed is that we now have effective medication for weight loss. Both Wegovy and Mounjaro produce clinically effective weight loss. You'll see that over 5% of patients in both the key trials achieved significant weight loss, so 86% in step 1 for Wegovy and 91% of patients with Mounjaro in Surmount. And it's really important to iterate that in the trial settings, just like the care we deliver at Oviva, this is only achieved through wraparound care and multidisciplinary support. It's not the drugs alone that they used in the trials. They had the full complementary MDT support throughout. I won't go through this slide in lots more detail, but actually, this will be there as a key reference for you to see. But both in step 1 and Surmount, you can see a large proportion of patients achieve in excess of 20% weight loss through the care that they receive. 32% of patients on Wegovy at the maximum tolerated dose achieved greater than 20% weight loss. So we have effective drugs, and that's what we use at Oviva. In terms of the access to weight management support in the NHS, we know that there is a real mismatch between demand and supply. And this is something that really is creating problems and adding to health equity constraints within the system, and really resulting in a two-tier system. Those that can access care and pay for it privately versus those that are left on long waiting lists, often in NHS settings. And I won't dwell on that too much longer, but you can see that the demand for these medications is high, with 4.2 million patients who would meet the eligibility criteria for Wegovy alone. I've alluded to some of the key challenges, and I think we're seeing that the lack of access to free at the point of use obesity care is really driving health inequalities and also adding to clinical risk. Often patients in the private sector will yo-yo in and out of treatment because of affordability and the high cost of these medications. We know that more often than not, they cannot access the highly invaluable wraparound care that they so need. These patients are complex from a medical complexity perspective, but also the socio-psychological complexity as well is really evident. And patients in the private sector can often not access that full wraparound support, and cost is a key barrier. This plays out in the evidence from mainly the US data, where medication adherence is much lower in this group of patients. And we know that one of the core drivers of that is cost and the complex nature of care delivery, and often patients not receiving the support they need to maintain sustainable weight loss and adhere to medication and treatment regimes. An overview of the medication treatment pathway that we have at Oviva. And you'll see that throughout this pathway, although of course we take full responsibility for prescribing medications on our pathway, and you'll be happy to know that we don't pass the responsibility for prescription back to GPs at any point in the journey. For the full 2 years, we continue to prescribe the GLP-1 medications for patients that meet the suitability and eligibility criteria. But throughout their journey, the focus is on shared decision making. And we do that because we know that best outcomes are achieved by getting patients the maximum dose they can tolerate, but also ensure medication adherence. And there'll be some patients that for various reasons want to go a bit slower in how they titrate, and others want to get to that maximum dose as quickly as possible. And we will tailor that journey for the patient. Patients at any point in our pathway can access MDT support. So our MDT occurs weekly and is led by a lead consultant. And at those meetings, you will have our lead psychologist, our lead dietitian, the full MDT mix, so that we can ensure that patients receive the holistic support they need in their journey with us to stay on their medications, to adhere to their treatment plan, and to develop that plan as is needed through that journey. Patients can be referred into that at any point. You'll also see that we offer bespoke coaching support via our app. So that mix of digital support to improve medication adherence is key. And patients can also access our prescriber query support line at any point in their journey, and we will get back to them to support them with side effect management. So you can see here on the screen here, the main side effects that patients may or may not experience as they start GLP-1s. There are some that are very predictable and common, and often are managed by simple means. Eating smaller meals, some small changes to lifestyle measures in terms of getting some fresh air, not lying down after eating. So simple things are what we guide patients towards. But the main side effects that they may experience, and the most common ones, are headache, some low-level GI symptoms, nausea, vomiting, stomach pain, for example. And these are common, but the main message to patients and the main thing that we know from our experience is that it's supporting patients to work through those, stay on the medications at the dose that they're on, and the side effects often fade. And that's the key message that we give patients through that journey and support them with key core side effect management throughout. And that's really important, because if patients are supported through side effect management, they adhere to the medication, they stay on it, and we know that they achieve better weight loss outcomes. That's only achievable with the full support that we have of the team around us, and you'll hear shortly from our lead dietitian and psychologist who also explain actually how they support this. But I think this is how we do it at Aviva in terms of the medication pathway, and really providing that full MDT support to provide good side effect management and support patients with achieving the maximum tolerated dose they can. It's really important to know that our learn content and information that patients are provided on their app also supports side effect management and learning in relation to how best to manage these. We make sure that, of course, where patients have really significant side effects, that they know where to go to seek help. We know a small proportion of patients may experience side effects like pancreatitis, and it's very rare, but we, of course, give patients strict safety netting advice that if they have severe, significant abdominal pain, they must seek more urgent help. But I'll stop there and I'll hand over to my colleagues to take you through the MDT support we provide.
Thank you, Shane. So my name's Juliette. I'm clinical expert dietitian within the Tier 3 pathway, and I'd like to share with you today some examples of how we support holistically with that wraparound care and what our nutrition team can support with that often goes well beyond nutrition and dietary advice. But let's start with the nutrition advice that we support our patients with. So firstly, I think it's important to say that we always work on evidence-based nutritional advice, but also that it's personalised to each patient. And that's one of the benefits of having a wide team of specialist dietitians and specialist nutritionists who are able to tailor that advice depending on patient complexity, depending on comorbidities, and also just depending on individual patient preferences and what those patient goals are as well. So every patient has the opportunity to speak with a a dietitian and make sure that they've got a personalised plan that helps them to reach their goals. But often the work that we're doing has a similar theme, and that is often changing or supporting our patients to change their relationship with food. And what you've probably experienced in working with patients yourself is that people will have had many, many years of experience of trying to reduce their weight, having tried many restrictive approaches in the past, and have often, for various reasons, built up a negative or challenging relationship with food that's based on restriction, and often feeling as if they're unable to achieve success in making any impactful changes. And what we see with the results of the weight loss medication, as Shane's just shown you, is that the medication does a lot of the support with the cutting down. So people can move away from restrictive approaches because often their appetite and their cravings and their food noise is suppressed to an extent that they can then focus on dietary quality. And often portion sizes are greatly reduced. So it's important that we really do focus on dietary quality, and actually we're shifting the focus to think about nutritional adequacy. Are they achieving enough protein? Are they achieving enough fiber, enough micronutrients to stay healthy? So there's the practical aspects to that and getting all the right food and the right nutrition in to do that. But there's also that relationship aspect of that and helping our patients to build that healthier relationship with food and not see food as something that you have to count calories in or restrict and cut down all the time, but as opportunities to get a good source of protein in or a good source of fiber in. And that takes time. And that's partly why we have a 2-year pathway to work with our patients to gradually rebuild that relationship with food over time, as well as make sure we're addressing that nutritional adequacy. But as I mentioned, it goes well beyond nutritional advice to our nutrition team support with, and we align very closely with our psychology team. But I won't say too much about that because Jacobina's got some amazing insights to share with you later. But we do work very closely with the psychology team to facilitate behaviour change for our patients, as well as thinking about that long-term behaviour change too. We'll also look at physical activity, and more on that in just a moment, and all other holistic aspects of healthy lifestyle. So we'll look at sleep management, stress management, social support, signposting to other services and resources. So going well beyond the dietary advice, and it is that holistic whole person care that is absolutely essential to supporting our patients in the right way. I wanted to just share with you some of these examples just now as frequently asked questions. And these are maybe just some of the insights from our patients and also from insights in how we work with our patients when they have these concerns. So as I mentioned, a lot of people will ask, how many calories should I eat, or what restrictive approach should I take? And we're really supporting patients to move away from heavily restrictive approaches where we see food as just a number and something that we need to battle against and cut down on, as to seeing it more as that opportunity to get the nutrition you need. So we don't find calorie counting to be a particularly useful approach in doing that. And we'll often try and shift that focus towards regular eating of smaller but balanced meals. And that doesn't happen overnight, it takes time. Sometimes our patients will ask us about supplements, they'll ask about meal replacements, and we do try to take a food first approach because in most cases you can get a much wider variety of nutrition from food-based sources. So if you took, for example, protein supplements, patients often ask us about that. We know protein is really important. Should I take a protein supplement? Our usual answer in most cases is that you can get the protein that you need from food. And when you do that, if you increase maybe some plant-based protein sources such as chickpeas, beans and lentils, then not only do you get the protein, but you get the fiber, you get the micronutrients, the minerals there as well. So that's the type of food-based approach we want to take because that's sustainable for long-term health as well. We do, however, recommend a standard A to Z multivitamin and mineral supplement for most of our patients who are on GLP-1 treatments, because often their intake is greatly reduced and that opportunity to get the wide variety of micronutrients is reduced alongside that too. But again, that's individualized advice to each patient depending on their circumstances. We've talked a lot about the relationship with food, and that is something that's a thread that runs through all of our care with our patients. And Shane mentioned side effects. So often our patients will come to the nutrition team first with questions about side effects that they're experiencing, whether that's nausea, constipation, reflux symptoms. And our dietitians and nutrition team can support with those first line approaches. So very much the same as the approaches that Shane's already mentioned. If we can manage those in the nutrition team alongside the nutrition coaching, then often that can prevent escalation to the medical team and allows that freeing up of the medical team time to focus on the more significant but less often occurring side effects as well. And then our patients will often ask us what happens when I stop the medication. And this is an area that a lot of people have a lot of understandable worry about. And we've built a really robust off-ramping service and program around that, which I'll tell you a little bit more detail about in a moment. But let's move on just now to physical activity and movement, because I think that when we're thinking about holistic care, this is absolutely essential. And we can't just focus on nutrition alone, and certainly not on weight loss alone, without considering the importance of physical activity and movement as part of that. We talked about changing the relationship with food, but actually there's a very similar journey in changing the relationship with physical activity. And a lot of people who've been trying for a long time to lose weight will have that relationship with exercise as, well, I need to do exercise to lose weight, but it's not helped in the past, or exercise doesn't work for me, or I have to go to the gym and burn 200 calories, and seeing that calorie count slowly count up on the machine is, incredibly dissatisfying. And again, we can change that focus. We can move away from I need to exercise to lose weight, because actually the medication can help with the weight loss. We can focus on activity for strength, for feeling healthy, or for the mood lift, for the associated health benefits with it, and for feeling good. So physical activity to help you to feel good in the moment. And again, it's that focus, that change in relationship, and we're there to support our patients to gradually shift that relationship. And as we do that, we often have to adapt again to patient complexity. And that might include, for example, patients with very limited mobility, very limited exercise experience. And we'll start really small with, for example, chair-based activities. And we've got lots of really practical guidance and videos to support with that, which is essential. The other essential thing is strength and resistance training, and making sure that everybody has an opportunity to experience strength and resistance training, and how that can help to boost their health, help them to feel better, but also help to minimize the loss of lean tissue during that weight loss period with the medications. And again, often that's starting very small, building that up with the use of really practical resources to help people. And then finally, the last thing I wanted to speak with you about today is what we call off-ramping, or also titration down of medication towards the end of the Wegovy journey. And this is incredibly relevant for people. And as I said before, often people ask about this right at the beginning. Well, what's going to happen when I stop the medication? We saw, widely published evidence about the risk of weight regain at the end of medication treatment. And often people, have seen headlines and they've got questions about this. And this is when the holistic support, it becomes even more important. So when someone's reducing their doses of Wegovy, their appetite will start to return. So will some of the food noise that they've been experiencing, and so will some of the challenges and the habits that they've managed to tackle will start to become more challenging again. And it's really important that we're there with our patients through that journey. So we can use practical appetite management strategies for satiety, such as using protein and fiber and hydration. We can use different structured dietary approaches to help people as well. But we also need to do the planning around, well, what were the challenging situations before you started the medication, and reflecting on that, and what can we put in place, and planning for lapse and relapse, and having strategies to manage that, anticipating that it's going to be a tough time, and having the strategies around that. Physical activity again becomes really important, because for weight maintenance, we know there's a lot of evidence to support physical activity there. But it also works as, appetite management and distraction from cravings, and generally that boost in mood as well. And this is another area where we work really closely with our psychology team. So it's a good opportunity for me now to hand over to Jakovina, who's going to share some more insights from a psychology point of view.
Thank you, Juliet, and welcome to everyone from me as well. So I'd like to I'd like to talk to you about what the psychology part of the program looks like in our Tier 3 service, and how we work with our patients and our colleagues to ensure that holistic care that is so crucial in a condition as complex as obesity. But first, I'd like to introduce you to some of our psychology team members. As you can see, we have a wide variety of expertise in our psychology team, with over 40 clinical and health psychologists, psychological well-being practitioners, and each and every one of them brings a fantastic level of experience and specialisms, which makes the team really well placed in working with complexity that we see so often in obesity. Our main goal in our Tier 3 psychology program is delivering psychological interventions safely and effectively in collaboration with the dietetics and the medical team. And we really aim to make the interventions as personalized as possible and really formulate each individual's difficulties, which can be complex and multifaceted. And this is exactly why we adopt a stepped care approach that we develop based on evidence, clinical expertise, and user feedback. We titrate the level of intervention based on patient preference and to make sure that our interventions are scalable and appropriate. We know that there is a high degree of variability in psychological need in our patients, and this is why we ensure that our pathways are as personalized as possible by formulating each individual's needs. For example, we know that eating disorders are a very common comorbidity, so we carefully assess eating disorder risk to ensure that we deliver our interventions safely and adapt them according to what every person needs. Equally, patients may have had experiences of trauma, which may have impacted their relationship with food. And in this case, again, we will ensure that they access the right step of care to understand and work with these difficulties as part of our intervention. This is what the psychology pathway looks like in our Tier 3 program. So patients go through a stage of assessment where they meet with one of our psychology practitioners who gather lots of information about the patient's journey, about their presentation. And this information is corroborated with a number of other measures and questionnaires that that the patients provide to us, alongside regular supervision that all of our psychologists and psychological wellbeing practitioners receive regularly. And at that stage, patients move on to the treatment phase, and according to what they need, what they've expressed to us, and what we feel is most appropriate for them, they will be allocated onto a specific step of care, ranging from guided self-help to having telephone or video calls with a clinical or a health psychologist. So we know that whilst patients are on weight loss medications, we have a really crucial window of opportunity to support them in creating long-term change. So we have adapted our practice to maximize the well-being of patients on GLP-1s. GLP-1s, we know, can make subconscious unhelpful habits more conscious, and therefore we try to create the space for meaningful change within our psychology input. So what we do, we try to embed behavior changes and healthier coping mechanisms for people. So for example, we address difficulties such as emotional eating by really carefully trying to identify with our patients any triggers or any difficult emotional experiences, and with them, again, finding other more effective ways to cope with these. We foster habit formation to support long-term health, such as incorporating mindful movement that benefits our patients beyond just weight loss and therefore makes them more likely to maintain these habits. We help our patients reshape their relationship with with their bodies and with weight by encouraging reflection, encouraging self-monitoring, helping them to change perhaps unhelpful thinking patterns that are contributing to weight difficulties. We see very often unhelpful thinking patterns such as self-criticism, self-blame, which fuels difficulties such as shame, feeling extreme shame, that we know in a lot of cases fuels unhelpful behaviors and sometimes pathological behaviors such as binge eating. And we address underlying psychological factors that contribute to these eating difficulties, such as shame and guilt, which again might have been fueled over many years through weight stigma and restrictive diets. So we really try to understand with each one of our patients about their own personal experiences, how they're also experiencing GLP-1s, how they're affecting their eating habits and relationship with food, relationship with their body, and really try to maximize this window of opportunity that we have to make sure that they maintain those changes in the long run. And I'm sure most of you will have read about this new Oxford study that found that patients on GLP-1 medication regained their weight 4 times faster at 18 or 20 months after stopping the medication. This is not surprising. Oh, sorry, if you don't mind putting yourselves on mute. Hopefully you can all hear me okay. So yes, the findings of the study. So this is not surprising, the first part, as we know that medication alone leads to weight regain without the appropriate behavioral support. But what was even more interesting about this study was that behavioral support, whilst it helped people lose more weight whilst they were on medication, it didn't slow down weight regain once people stopped taking the medication. And one possible hypothesis to explain this is that whilst people are on GLP-1 medication, their appetite is suppressed, which means that people are not consciously applying behavioral change and therefore might not be able to maintain it when the medication stops doing the heavy lifting. And this is why psychology input is so crucial at this time, because it's a great opportunity for psychological preparation, for mental preparation, for patients to consciously and intentionally understand their relationships with food and hunger, and build conscious and intentional strategies for when appetite and cravings return. We also see that GLP-1 medications can have a ripple effect on a number of other areas that can impact patients' well-being. Firstly, patients tend to experience a reduction in food noise, which can lead to fewer intrusive thoughts about food, and therefore food becomes less threatening, less stressful, less fearful. There's lots of shifts in appetite and food preferences, which makes it a lot easier for our patients to think about the choices that they're making, to make those choices more conscious, less automatic, and therefore choose to make healthier choices. And we also see a ripple effect across other areas as well, such as alcohol consumption or smoking. And generally people, in our experience with GLP-1s, they really create this space to think about other healthier coping mechanisms, such as seeking social support, finding other ways of regulating emotions beyond food, and meeting their needs in a different, much more effective way. We also very often see that the risk of binge eating and emotional eating is reduced. Partially because the food noise is reduced, and again because of what I mentioned before, that there is more space for people to actually think about how to meet their emotional needs differently, and therefore purposeful behavior change becomes more manageable. So medication, due to the medication, and improved well-being. So I want to share a bit of data as well from our patients. So this is a set of data directly from our patients that show these improvements. So you can see in the dark green bar the percentage of patients who rated their general health, their quality of life, their physical health, and their mental health as good or better at the beginning of the program. And in the light green bar, you can see the percentage of patients that rated these same areas as good or better after 6 months on our program. And you can see that there are some important changes here, particularly in physical health and general health, which I think speaks to the effectiveness of our work here. I'm going to pass on to Lucy, I believe, for the last bit, and thank you very much.
Amazing, thank you so much. We are on the home stretch. Just a quick reminder, if you do have any questions for any of our speakers so far about the psychology, the dietetic strands, the medication, any questions at all or about the service, please do pop them into the Q&A, and we'll make sure we carve out the last 10 minutes to get to those questions. So I'm just going to wrap up. And I just wanted to firstly say a huge thank you for the clinical team for sharing their day-to-day work and their insights from our patients and achievements also. And finally, just want to touch on how we can really work together to get the support to patients as smoothly as possible. So what I hope our team has demonstrated today is that we consistently see that when patients have access to an MDT, clinicians, dietetics, psychological support, and our digital tools, they feel much more confident in managing their own health. And I've just popped some data in this slide here, and this is reflecting our patients' independence in essence. So after 9 months on the Oviva programme, we're seeing a 45% reduction in sick days. We've just reanalyzed another data set, and it's looking more like 50%, in excess of 50%. Bit of a spoiler alert of some more data to come this month. We also see a decrease in the need for GP touch points. So here you can see surgery visits down by 43%. And we don't see this as replacing GP care, but as we hopefully can show, that providing that wraparound service with that intensive support, hopefully really enables patients to feel confident in their health journey and maybe give a little bit more breathing space in busy clinics. And then finally, just to touch on referring into the service. So hopefully this is designed to be as low friction as possible, and you can find all of our forms on this link here, oviva.com/refer, or by simply searching Tier 3 Weight Management Oviva directly in systems, ERS, Ardens, or EMIS. So to close out, in short, as all of us know on this call, GLP-1s and weight loss medications are indeed a fantastic tool in the toolkit for treating complex obesity, but they really do reach their full potential when paired with that behavioural and psychological and dietetic support to really sustain health for a lifetime. So let's open up the floor. Shane, Juliet, Ikaterina, please join me back for Q&A. So I'm going to go with Sally first. I've given Sally's question a great thumbs up from the beginning. I suppose the question we all want to know the answer to is, what happens after the 2 years? Shane, can I come to you for this one?
Yeah, absolutely. So, of course, the full program that we have on offer for patients on the medication pathway is 2 years, and that's the length of, that we're able to offer that continuous support for. We're really proactively, as Juliet alluded to, we're really proactively thinking, what do we do to support patients towards the end of their journey? And we're actually offering all of our patients that opportunity to have structured, supported help in terms of down titrating and coming off that medication slowly towards the end of our program. So that's definitely one of the core actions that we're taking. I think in terms of what the long-term future is for GLP-1 medication and whether some patients stay on it at lower doses, perhaps long-term, there's emerging evidence and emerging policy in that field. So I think it's watch this space. It's dependent on sort of what's accessible within the NHS, what guidance comes out in terms of long-term to support long-term outcomes in that way. We're not quite there yet, and we're sort of actively watching that space and thinking, what can we do to best support patients? And at the moment, as I said, our aim for this is to support sustainable weight loss through their journey with us, but actually think actively in the final 6 months of the program as to how we proactively support patients with gradually coming off the medication.
Thanks, Shane. And I think that answers Sally's other part of the question. Give me a thumbs up if it does, Sally. So Sally's also added, do patients need to come off the meds, or can they stay on it long term? Would you stay on a lower maintenance dose, reduce or stop? And she's quoted, I asked yesterday and got the impression there was no evidence for which is the best end game.
I think you're absolutely right that this is a space where there is not a clear evidence base. And I think our own experience at Viva is that patients actually, some are in different journey trajectories, and it's very individualized. Some patients will have still not reached their core weight loss goal at 18 months and will want to keep going with the medication right the way to the end of the pathway. For others, they've achieved a good level of weight loss, and they now want to think how they sustain those habits, gradually coming off the medication. As I said, we're watching that space. We're actively adding to the evidence base and looking at what we do in this space, but there are no clear sort of trial evidence that says one approach is better than the other. But we absolutely know that obesity, we're increasingly recognizing, is a chronic disease, and there'll be various points in patients' journeys and lives where they have to seek more additional support, and whether that's through dietetic and lifestyle support or more medication. The trials are ongoing to evidence actually what combination of both are the best support long term.
Amazing, thank you, Shane, and I hope that answers that, Sally. I'm going to go to a few questions we've had come in around food noise, actually. Yeah, Kavina, are you okay to pick up some of these? So I have one come in around what happens to the food noise after stopping GLP-1s? And then there's another angle, which is another great question. I've read the reduction of food noise can also lead to the reduction of food enjoyment, and in some cases, low mood. Is this something you found? So two parts. One is kind of the food noise reduction whilst on GLP-1 therapy. And then the other parts from another person's question, which is Fab, is about what happens after you come off and the food noise.
Really good questions. And yes, so I'll start with the first part, which is what happens after the 2 years. We do see for some patients that the food noise returns, perhaps not to the same extent as it was before. However, what we really try to do, and we do have 2 years to do this, which is a significant amount of time, to really build patients' tolerance to food noise and really build techniques and tools to help them manage that. And we actually do see, I can remember lots of patients that I've worked with that after the 2 years, they've really developed some good habits, some good routines. Not perfect by any means, but they really have the tools to actually reflect on if something changes, if my circumstances change, how will I be able to, what are the things that I need to look at? How am I going to be able to manage the food noise that they have lots of experience in? So we really try to build on that. So to answer briefly, sometimes the food noise returns, but there are tools and practices that we really try to help our patients build to manage that. And in terms of the second part, which is around enjoyment, this is a fantastic question because it really gives us a great opportunity to look at people's relationship with food and what food means for everyone. So, of course, food is to be enjoyed, and we love it when people actually enjoy food and have this relationship with food. If that goes away, how can we explore this? How can we bring other ways of enjoyment? And how can we actually make food enjoyable again? Maybe through a different lens, maybe in a different format, but it really gives us a good space to explore people's relationship with food and enjoyment, but primarily with food. I hope that answers the question.
Amazing. Thank you, Kavina. I'm just going to come to one question about CPD certificates. It's a really great question. We haven't to date, but I've been reassured by the team we are going forward from our next webinar going to be providing CPD certificates because it has been a request that's come in previously. So we are working on it, and for our next webinar series, we will be providing CBT. Can't even get my words out. CBT. We won't be providing that. We're providing CPD certificates. I am going to come to you next, Juliet. We've got a brilliant question in about other strategies. So would you recommend other strategies like intermittent fasting?
Yeah, it's a really good question. Thank you for that. And I think the quick answer is yes, but the longer answer is it very much depends on the person. And I think that one of the advantages of taking that individualized, personalized approach is that you can tailor it to what works for that individual. We don't ever want to take a one-size-fits-all approach or recommend one dietary approach as being the right thing for each person, because it simply isn't. And you have to find the thing that fits in with that person's priorities and their lifestyle. So intermittent fasting does work for some individuals, but it is one that we're particularly cautious with. The reason being is that we often find that patients who are living with obesity have often been through very restrictive patterns in the past. And that often they experience cycles of restriction, which can lead to overeating, and in some cases binge eating as well. So there is a place for intermittent fasting, but not for everybody. And if it was going to, because of the level of restriction, increase somebody's risk of overeating later, then we'd prefer to find a different dietary strategy that would work better for them. But as you know, there are different versions of intermittent fasting too, and some of the versions where you have an eating window that simply cuts out snacking in the evening can work really well for a lot of people too. So very much adapting to the individual. And the same goes for other dietary approaches as well, so such as modified carbohydrate diets, such as the use of meal replacement shakes for 1 or 2 meals per day, the use of the Mediterranean diet approaches. All of those can be applicable to different people in different situations.
Thank you, Juliet, I'm going to leave you on unmute if that's okay. We had a question in before in the history and the questions asking about physiotherapists, because I know in your section you spoke about the physical activity element of our support. The question was around physiotherapists being on our MDT. Do we have any?
No, we don't currently at the moment. There's a really good question, because I think, as we expand, we can see the need for that. I think if someone at the moment specifically required physiotherapy, over and above general exercise advice and support and guidance, which we can provide, then what we can do is make sure that we give patients the right signposting. So a lot of what we do is directing patients to find the right resources in their local area too. So linking in with local areas is really important. But a lot of our resources to support patients with physical activity and movement, such as strength training guidance, has been developed in conjunction with either physiotherapists or with qualified exercise professionals too. So they're maybe not directly seeing patients, but they have influenced the material that we're using with patients.
Amazing. Thank you, Juliet. I'm going to come to the question that's just come in about emotional eaters. Kavina, I'm going to come back to you for this one from Claire. It says, do GLP-1s actually help emotional eaters? How do you change association of eating to ease stress? And do you suggest habit stacking?
I think GLP-1s can certainly help with emotional eating. Again, as I was saying before, because they create that space between the urge to go to food and acting on it. With emotional eating, a lot of the times, again, we try to see what's underneath, what is food trying to regulate? Because emotional eating for a lot of people is a way to regulate difficult emotions. It can be anything: stress, anger, frustration, sadness, low mood. So what we try and do with our patients is, as they have this reduction in food noise, reduction in the automatic sort of going to food, try to find other healthier and probably more effective strategies to regulate their emotions or to cope with whatever the difficult emotion might be. At the same time, without demonizing food, because we don't want to create any guilt around emotional eating. All humans have a relationship with food that sometimes brings comfort, and that's absolutely fine. But we want to make sure that we have a range of ways that we can regulate our emotions and cope with difficult situations. So GLP-1s can certainly help. And to answer the question about habit stacking, yes, on a more behavioral level, we definitely use lots of tools and lots of conversations with our patients around understanding habit cues, building newer habits, healthier habits, using habit stacking techniques.
Amazing. Thank you, Kavina. I can just see there's a couple of questions to wrap up that hopefully I can answer here around the mode of delivery. So indeed, all of the care is fully remote from the comfort of a patient's own home. So telephone calls and or via our app for some of our healthcare interaction, if people are able to use that as well. But yeah, all remote care. I think we are coming to the end of time. So I just want to finalise by saying a huge, huge thank you to our speakers today. And thank you so much to our audience for engaging in some really incredible questions and challenging our team, which is brilliant. If you do have any questions around